The indications for intubation are essentially the same for older adults and younger adults. However, I think anyone who has even a little experience knows that the older patient is far more likely to need to be intubated for conditions that we just don't see in the younger patient. Things you need to be aware of in the older patient is that the oxygen reserve is much lower. This is for a number of reasons. One, they may not have the carrying capacity within their hemoglobin as they get older. Number two, the heart is greatly affected, and you do not have the strong heart that you would in a younger person. Therefore, they cannot compensate when they need more oxygen. Other things that may happen in the older patient is clearly we know that they have many more serious problems that may require intubation, such as problems with their heart, congestive heart failure, as well as their lungs. COPD is obviously much more common in the older patient. So you need to have a much higher level of suspicion and intubate earlier in the older adult because they will decompensate much more quickly than a younger patient.
The indications for intubation are the impending respiratory failure, the decreased level of consciousness, the general rule of less than 8 intubate, referring to a less than 8 on a Glasgow coma scale. You need to intubate, that always applies. And you begin to judge how much of a struggle that person is having breathing. I think it goes without saying that a person in respiratory arrest or cardiac arrest needs to be intubated. But we should also remember we have other tools for managing that airway. If they're in cardiac arrest, there's a lot of research that's showing that we want to make sure we're doing that chest compression, so we don't want to take a lot of time to intubate. So consider an alternative airway like a King airway or a combi tube so we're able to place it quickly. But for an adult that's breathing, remember it's a last resort to intubate. So let's consider, is oxygen, high flow oxygen alone going to be enough? Is the CPAP going to be enough? And if we get to that point where we decide, yes, absolutely, CPAP's not working, the high flow oxygen isn't working, I need to intubate, make sure you have all the resources available, consider whether or not you want to go through a rapid sequence induction to intubate the patient.
Clearly, we look at several things in any patient. One is the ability to protect the airway. Two is inadequate ventilation, and I need to talk about that a little bit more. Inadequate ventilation is not just the SAT, but it can also be the amount of carbon dioxide. As we all know, patients can have CO2 narcosis. This is much more common in the older patient, and it is a real problem if you put high flow oxygen on these patients, that they may raise their carbon dioxide and go unconscious or lose their ability to protect their airway. So both of the main indications, protection of the airway and provision of ventilation, are much higher in the older adult. In addition, the course of how the patient is going to do must be taken into effect. If you have a questionable airway in an older patient and it's going to take longer to reverse the cause that is causing them to have problems with their airway, it is far better to go ahead and intubate them so you're not having a long drawn-out course where you're worried about their airway, whereas in a younger patient it may turn around much more quickly. A couple of the pearls that I would like to impart on this is that we traditionally have used the gag reflex as an indication for intubation. This is not a good indication of whether a patient is able to protect their airway, as studies have shown that up to 30% of patients that are awake and normal do not have a normal gag reflex. The two things that I would like to have you look at are, number one, can the patient control their secretions? Are they drooling or are they pooling secretions? And that's another thing you will find when you use one of the oropharyngeal airways. And are they able to speak? Those are the two best indications whether they have intact protective reflexes. Other things are that the older patient is going to get much more tired if they're working hard, say with CHF or COPD, and you must anticipate intubating them before then, because once you lose their ability to ventilate, it is a crash airway. That's a very dangerous situation, and even short periods of hypoxia can lead to very serious problems with outcome in the older adult. The indications for placing a nasopharyngeal airway and oropharyngeal airway in the older adult, again, are the same as for a younger patient, but there are several things we need to talk about that are far more common and important in an older patient. As we age, we lose the ability to maintain tone in our airway. And when you start to lose consciousness, and this may be indicated both by the level of consciousness of the patient or when they're working very hard to breathe, you may lose the ability to keep the airway open. Therefore, you have a much lower indication for placing a nasopharyngeal airway or an oropharyngeal airway in the adults, because they are much more, older adults, because they're much more likely to occlude their airway earlier and with less provocation than in a younger patient. This is particularly true if you're giving any medication for sedation. You may go from having an intact airway to not having an airway at all with even a little bit of pain medication or sedative medication. So therefore, I would strongly recommend that you consider using some type of airway adjunct far earlier in the older adult so that they don't occlude their airway, usually by their tongue or loss of tone in their airway musculature.
When you're actually ventilating a patient, an older patient, you need to be concerned about what is their lung compliance. If you may have somebody who's got a long history of lung disease, and it may be more difficult for you to ventilate. So it'll be physically harder to squeeze the bag. And it's difficult to know, is it harder for me to squeeze the bag because I've just created a pneumothorax? Or is that what their lungs are normally like? So it's probably wise, particularly in a patient who's just in respiratory arrest or respiratory failure or tract breathing for them, to have a very experienced person managing that bag valve mask so they can get comfortable and they realize, okay, it's more difficult for me to bag than it was, or everything's going nice and smooth. If we haven't gotten to the point where an advanced airway is in place, the mask seal can be challenging, particularly if the patient has dentures and we've removed them, which is appropriate. It changes their facial anatomy, where it can be difficult for us to get a good seal around their mouth. So you need to consider, should I be using a blob mask? Should I be using, am I using the right technique, the EC technique, to make sure that I'm getting a good mask seal with what I have available to me?
When